Good morning. Today I'm going to talk about femoral neck fractures or fracture neck of femur, which is one of the commonest fractures in human being. Regarding the epidemiology, it has a bimodal distribution. The commonest fracture is in the elderly population. Incidence doubles each decade beyond age 50, higher in Caucasians, smokers, lower BMI, and excessive caffeine intake and alcohol intake. Those are the factors, which causes osteoporosis. In elderly people, those who are osteoporotic, they are more prone to develop a fracture neck of femur by a minimal trauma, by fall from a sitting height or fall from a standing height. And of course, it occurs in young people also, but it's mostly due to high energy trauma, and occurs in children. Incidence is children is much low, but they have a very special problem of high rate of non-union. So these are those. I'm not going to talk about fracture neck femur in children. If you know the anatomy, this is the epiphysis. Physial closure occurs at around 16. Neck of femur means this is a intertrochanteric area. Anteriorly, the capsule attaches here. Posteriorly also is slightly proximally. This part is the fracture neck of the, this is the head. This part is the head. And this is the body. And this is the neck. Any fracture occurring in this area is a fracture neck of femur. This is an intracapsular fracture. Intracapsular fracture neck of the femur poses a difficult problem because of the low rate of union and high rate of vascular necrosis even after union. I am coming to those later on. You see, the neck shaft angle is usually 130 degree or maybe 127 degree or plus minus 7 degree, and anteversion is around 10 degree. Previously, we used to call it about 15 degree. Now it has been seen that it is about 10 degree. And this is the strongest part of the femoral neck. This is, there occurs condensation of trabeculae. This is called a calcar femorale. Calcar femorale. This is a posteromedial dense plate of bone. This is the line of weight bearing here. So that's why this is a dense part of bone. If you consider the blood supply, it's due to lateral epiphyseal artery. This is the lateral epiphyseal artery. This is the terminal branch of medial femoral circumflex artery. This is the predominant blood supply to weight-bearing dome of head. They form a ring here, arterial ring here. From here, retinacular vessels, they go like this. They penetrate the head. If you see a anatomical specimen, you can see small pits here. Those are the entry points of the retinacular vessels. And these retinacular vessels lie on the bone itself. After fracture, blood supply depends on retinacular vessels. So if there is greater fracture displacement, there is greater risk of retinacular vessel disruption. And as this is an intracapsular fracture, as the capsule is intact, so when there is retinacular vessels are disrupted, so there is blood accumulation inside the capsule, that causes a tamponade effect. That means when their blood accumulates inside the capsule, capsule cannot extend very far, so that causes pressure on the blood vessels, retinacular blood vessels, further stopping the blood supply to the femoral head. So there is theoretical risk of avascular necrosis with increased pressure. These are the, how do you diagnose it? It's a typical attitude of the limb. Limb is lying, the patient falls on the ground and is unable to get up, unable to take weight on that particular limb. When he comes to the doctor or the doctor goes to see him, he sees the lower limb is helplessly externally rotated. Helplessly externally rotated. He cannot lift it up. The diagnosis is confirmed by a plain film, plain X-ray, AP view or a lateral view. It's difficult to take a true lateral view. AP view is sufficient in most of the cases. So whenever there is a history of fall, the patient is unable to get up and take weight on that particular limb and is seen as lying supine with the lower limb helplessly externally rotated, it should be taken as a fracture neck of femur unless proved otherwise. One should take an X-ray to confirm or disprove the diagnosis. In cases of some doubts, when if the X-ray quality is not very good, like in this particular X-ray, one can go for a CT scan to look for the displacement of the fracture. Here is the fracture line, or a comminution. MRI is only indicated in cases of occult femoral neck fracture. That is, in X-ray the fracture is not very obvious. Consider MRI in an elderly patient who is persistently unable to weight bear. Here you can see the occult fracture. This is 100% sensitive and specific. May reduce cost by shortening time to diagnosis. This is how do you classify this? As I said, this is the line of the capsule. Anything proximal to this is a fracture neck of the femur. It's divided into two, subcapital, and this is subcapital, and then another is a transcervical. And this Garden classification is very, very popular. It depends on the displacement of the fracture. Here in a Garden grade 1, it's an incomplete fracture. This fracture is clearly visible only in CT scan. The head is tilted backwards. And this is Garden 2. There is complete fracture, but it's a non-displaced. This is a fracture line. And Garden 3 is complete, but there is partial displacement. And Garden 4 is complete and full displacement, such as this is the head and this is the neck. So this should have gone here. So this is completely displaced. This is Garden 4. There is another classification. This is a mechanical classification. This is called a Pauwels Classification. Here, this is type 1. If you draw a horizontal line on the top of the head and the line along the fracture line, if the angle is less than 30 degrees, then this is a stable fracture. As the patient tries to bear weight or even during muscle contractions, this fracture gets compressed. And this is type 2 if this horizontal line and the fracture line creates an angle of around 50 degrees. This is type 2. This is less stable. And this is the maximally displaced. This is the type 3. This is the horizontal line and this is the fracture line. This is the fracture line. This is 70 degrees or more. There is always a shearing strain here. I mean, these two fragments, they tend to be apart all the time. This is a most unstable fracture. So this has a relationship with the prognosis. Even Garden is also have the type 4. There is no continuity. That is also has a relationship with the prognosis. Treatment goals are geriatric patients. They have to be mobilized as early as possible. Weight bearing as tolerated and minimize period of bed rest, because a prolonged bed rest will cause deep vein thrombosis leading to pulmonary embolism and death, or respiratory embarrassment leading to congestion and hypostatic congestion and pneumonia, basal pneumonia. There may be urinary problems, and there are problems of bed sore. The best treatment of bed sore is prevention. It's basically a pressure sore. The pressure has to be relieved. So our idea in geriatric patients is to minimize the period of bed rest. The patient should be up and about as early as possible. And to minimize the surgical morbidity, that is the safest operation has to be done, and decrease chance of reoperation. Only one operation is to be done. Because these patients have a lot of comorbidities such as hypertension, diabetes, COPD, neurological disorders, etc., etc. This is the fracture line. In a young patient, you can see there are comminution at the fracture site. Some pieces are there. The femoral, one should try to preserve the femoral head, avoid deformity, improves union rate. Optimal or choice is to go for a close reduction and internal fixation to save the head, minimize vascular injury. So choice is should be operated as early as possible. Non-operative, there is very little role, less than 1%. Usually high cooperative risk patient, those who are terminally ill, only those patients. And our target is to mobilize early. Treatment options in young patients, reduction, either it's a closed reduction with the help of an image intensifier by manipulating the thigh and the lower limb. The reduction is checked by image intensifier and reduction is maintained by percutaneous screws, 3 screws. I'll show you the examples. If closed reduction is not possible, then one should go for an open reduction and internal fixation by the same 3 screws. But this is only for young patients. In geriatric patients, as the chance of union is much less, mainly for Garden 4 cases or Pauwels 3, as in different centers, the chance of non-union after internal fixation is maybe up to 50% or more. In those cases, naturally those who are having non-union, they need to be operated after 6 months for a replacement arthroplasty. So in those elderly patients, such was 60 plus, we straightforward go for a arthroplasty. That is, we resect the femoral head and replace it. So replacement arthroplasty, either it's a hemi-arthroplasty, we replace the femoral head, or maybe total hip arthroplasty also in younger patients. Pre-operative considerations, timing of open reduction internal fixation in young, surgical urgency. This may unkink vessels due to the displacement of the fracture, maybe some vessels are kinked. So if it is properly reduced, they may unkink the vessels, release tamponade in capsule. The blood comes out after operation, that releases the intracapsular pressure. Effect of time to reduction is controversial, but generally try to get reduced and fixed within 12 to 24 hours. Because they do not have much comorbidity, they should undergo operation as early as possible, that is maximum within 24 hours. But in preoperative considerations in geriatric patients, elderly, 60 plus, surgical timing, surgical urgency in relatively healthy patients, those who are not having gross comorbidities, that is hypertension, even if it is there, it's controlled. If diabetic, that is also well controlled. Then in those cases, it should be early surgical urgency. In relatively healthy patients, they give rise to decreased mortality, complications, and length of stay. But surgical delay up to 72 hours for medical stabilization warranted in unhealthy patients. That does not mean that early operation does not mean that one should take great risk, because if the patient is having uncontrolled hypertension or cardiac arrhythmia or a diabetes, that should be controlled first. In these days, it's possible to, in a hospital, good hospital setup, it is possible to control these comorbidities within 72 hours, then one can go for operation. It has been seen that there is 2.25 times increase in mortality if there is more than 4-day delay. This is how close reduction is done. This is an orthopedic table, spatial table. The patient is placed like this lower limb, there is some amount of traction is there, and this can be abducted, adducted, or rotated, internally rotated, externally rotated, and accordingly to be checked by image intensifier. This is the image intensifier. When you come to OT, you can take a look at the image intensifier, that is a X-ray. If the position is okay, then we, through a very short incision, we fix the fractures with 3 screws. If closed reduction is not possible, it can be done with the open approach. This is the head, this is the neck, fractured neck, and this is the trochanteric area. This is held by a clamp, then 3 screws are placed. These are the fixation constructs. Most popular is 3 screws like this. 2-3 screws, or some people are also using this apparatus. This is a one large screw. There is a side plate. This is called a dynamic hip screw, DHS, dynamic hip screw. So mostly these 2 implants are used for a fractured neck of femur. This is another example. 3 screws or a sliding hip screw. Some people are putting a plate. This is done by open reduction, putting a small plate here. Ideally fixed within 24 hours, young fracture neck femur summary. Follow closely for shortening, AVN and non-union. Geriatric fracture neck of femur summary. MRI to rule out occult fracture in older patients unable to bear weight. Closed reduction, percutaneous spinning, percutaneous screws for valgus impacted, that is Garden 1 or maybe Garden 2, the non-displaced fractures. But in case of displaced fractures, Garden 3 and 4, as the chance of non-union is very high, straightforward replacement arthroplasty is indicated. Consider total hip arthroplasty for active older patients. What are the problems, special problems in fracture neck of femur? One is a non-union. 0 to 5% even in non-displaced fractures. Those non-displaced fractures, later on they go on to displacement. 9 to 35% in displaced fractures. These are all in excellent centers, maybe much more in less equipped centers, that is, goes up to 50%. Increased incidence with posterior comminution, initial displacement, imperfect reduction, and non-compressive fixations. This is one fracture which was fixed by 3 screws. It was not healing properly. CT scan is required to judge the amount of healing, lack of healing. So non-union in treatment is elderly patients, arthroplasty, replacement arthroplasty, but results typically not as good as primary elective arthroplasty because it's always a bit difficult to do a revision operation. The results are not so good. Maybe girdlestone resection arthroplasty, this was of choice even 50, 60 years back when this quality of artificial joints were not available. These are available since 1960s. Then people used to excise the femoral head. That led to gross instability, but patients were able to squat and sit cross-legged. But there was associated shortening. That used to be managed by shoe raise. There is, for a young patient, there is another treatment for non-union is there is a valgus osteotomy. You remove a triangular piece of bone here, then fix it internally. This is called a blade plate internally, so that this neck shaft angle is changed. Here is the fracture site. That leads to compression at the fracture site. This is called a Pauwels osteotomy. It went on to heal. The fracture healed. Other problem is osteonecrosis or a AVN, a vascular necrosis. It occurs in 20 to 45% of displaced fractures. Even after fracture healing, this can be caused, even fracture has healed, still there is osteonecrosis. 20 to 45% displaced fractures. Increased incidence with inadequate reduction, delayed reduction, initial displacement, that means there was vascular disruptions, associated hip dislocation, and query sliding hip screws. If there is osteonecrosis, it takes about 6 months to 2 years to develop. Even in cases of healed fracture, then the only way out is to remove the femoral head and go for a total hip replacement. Because hemiarthroplasty, what happens, in osteonecrosis or AVN, avascular necrosis, it's a dead bone. It's a dead bone, so it collapses. It is unable to bear the body weight, it collapses, leading to a lot of deformity. That means if the articular surface is incongruous, then it leads to damage to the acetabular articular cartilage with which it makes a joint. So both these articular surfaces are damaged, so leading to arthritis and severe pain at the hip joint. We get a lot of cases of osteonecrosis. The only option is a total hip arthroplasty. Even if the patient is a bit young, say 40, 45, we'll have to go for a total hip arthroplasty. Only risk is we do not know how much or how many years this artificial joint will last. Maybe 15, 20, 25, 30 years. After that, if it fails, then we'll have to go again and do a revision total hip replacement. Yeah. These are in short the problems of fracture neck of femur. Thank you very much for your attention.